Charlie, we are again here to discuss our academics. And now today we will be discussing our fifth case of interesting diabetes. And for this, we have learned faculty of Dr. Surender Kumar, additional principal, Medical College Bikaner, and senior professor medicine. And before we start for the academics, I will like to invite Dr. K K Pareek sir to say a few words for all the participants. Dr. Pareek sir.
Thank you, Dr. Keswani. Good evening, friends. It's really a great pleasure to be a part of this very important series of educative case-based discussion on diabetes. I think it is the fifth case-based discussion in diabetes today we are having. I would like to extend my sincere thanks and will definitely appreciate the efforts of our dynamic president, Dr. Girish Mathur, in bringing out this case-based discussion in diabetes, which is a very educative series of lectures and discussions by the legends of diabetes. So I welcome our President, Dr. Girish Mathur, the Dynamic Project Director of this series of case-based discussion, Dr. Prakash Keswani, a leading endocrinologist of the state. I would also like to extend a warm welcome to Dr. Surender Kumar Verma, additional principal and senior professor, and a wonderful person and good friend of mine. We have got three very learned panelists: Dr. Ajay Shah, head of the Department of Endocrinology, S.D.M.H Hospital; Dr. G D Ramchandani, a dynamic secretary of RSSDI, a great academician; and Dr. Manoj Saluja, senior professor of medicine, Government College, Kota. So today we will have case-based discussion on topic क्या है?
So this is something.
We will have a discussion on some case.
Yes,
that's right. So thank you very much, Dr. Prakash Keswani, to be making me the part of this very important discussion, and I wish a great success to this program. Thank you very much.
Thank you, sir. Thank you for your kind words. And we are lucky that our dynamic president of API, our leader and the man behind all these academic activities, Dr. Girish Mathur sir. And I will request Dr. Girish Mathur sir to say a few words before we go for the academics.
Thank you, Prakash ji. Good evening, friends. It's truly a pleasure to be with you all on this fifth session of online series of case-based discussion in diabetes organized by RSSDI Rajasthan Chapter. I welcome you all at this academic meet. All previous sessions were very well received by our esteemed members. I wish to extend my sincere thanks with folded hands to our mentor, Dr. K K Pareek, for his gracious presence. He has always been a great source of inspiration for all of us. I also thank my dear friend, Dr. Prakash Keswani, for his persistent efforts in designing and executing this interactive program. I cannot thank him enough for his very sincere efforts. I'm also grateful to our dynamic secretary, Rajasthan RSDI, Dr. G D Ramchandani, for his continuous help, support. I welcome today's speaker, Dr. Surender Kumar, Professor in Medicine and Additional Principal, SP Medical College, Bikaner. I also welcome the esteemed panelist, Dr. G D Ramchandani, Dr. Ajay Shah, Senior Endocrinologist, S.D.M.H Jaipur, Dr. Manoj Saluja, Senior Professor Medicine, Government Medical College, Kota. I am sure we are going to witness a very enlightened discussion on a case in diabetes today. My very best wishes to the program. Thank you so much.
Thank you, sir. Thank you for your kind words. And now we move towards our academic activity. I invite Dr. Surender Kumar to start, please, your case.
Thank you, sir. Thank you very much. Good evening, sir. Dr. Pareek, sir. Dr. Girish Mathur, sir. Dr. Ramchandani, sir. And the senior faculties. And Dr. Keswani, sir. Thank you very much for giving me chance to speak as a case discussion basis here. Today, I am presenting a case. We are facing it day to day about the HbA1c and its parameter. The errors and the discordant are usually present during the estimation of HbA1c. So we will see the case usually presented in our diabetic center. I collected such type of the cases here and giving the presentation today. Thank you. Thank you very much, Keswani sir. There's one patient, Mr. Tarachan.
You have to make it slideshow.
Yes, sir. Slides is going on here, sir.
समझ आ गई मेरी बात क्या करना चाह रहा हूं?
So slideshow, you have to make it slideshow. This is
Not moving.
हाँ.
Slides are not moving, dear.
Yes.
हाँ, slideshow पे दबाना करना होगा, क्लिक जहाँ आपके स्क्रीन में राइट लेफ्ट
ये है ना slide show. ये यहाँ है ना ये
फर्स्ट लिखा हुआ फ्रॉम बिगिनिंग, वहां दबा दो आप. लेफ्ट हैंड साइड पे इस पे, हाँ, इसके उससे भी थोड़ा उधर, और लेफ्ट और लेफ्ट और लेफ्ट और लेफ्ट और लेफ्ट. हाँ,
हो गया.
हाँ,
हो गया.
सर प्रणाम सर, गुड इवनिंग.
नमस्कार. आइए, बहुत लेट आ रहे हो.
हाँ अनिल जी.
सर प्रणाम.
हाँ नमस्ते अनिल जी.
तो ये हुआ नहीं अभी तक.
बढ़िया सर, आप बताएं.
अभी भी नहीं आया.
नहीं, पहले स्लाइड शो
ये सर,
जहाँ लिखा हुआ है वहां
ये
दबाइए.
राइट में कटोरी बनी हुई है, इसमें क्लिक करना नीचे.
हाँ
सर F5 दबा दीजिए. F5
के नीचे स्टार्ट स्लाइड शो.
सर F5 दबा दीजिए.
ये रहा
F5
ये है ना स्लाइड शो.
F और 5.
F5
हो नहीं रहा सर उससे भी.
F5 सर.
F5 ऑलरेडी आई.
F5 कहाँ पर है?
F और 5 दोनों सर.
ये रहा स्लाइड शो.
हो गया सर. अब
लैपटॉप के ऊपर F5 होगा, उस पर कर
नहीं हुआ, नहीं हुआ.
नो सर.
यहाँ नीचे जहाँ आपकी फोटो दिखी है, सबसे नीचे फोटो, उसके वहां एक कप बना हुआ है, और नीचे ले आइए, और नीचे, हाँ, यहाँ करके देखो एक बार फिर से. हाँ,
अब आया सर.
कब बनाया ना ये यहाँ दबाओ.
कप पे कर लो, इस पे हो नहीं रहा है, आप इस पे कर लो. ये आपके जो फोटो जो नीचे एकदम
सर राइट साइड लोअर कॉर्नर पे देखिए. राइट साइड लोअर कॉर्नर पे 87% के पास में जो आइकन बना हुआ है, 87% के पास में जो आइकन बना हुआ है, 87% के.
थोड़ा लेफ्ट ले लो, थोड़ा लेफ्ट ले लो.
हाँ,
हाँ,
ये
ये इसको दबाओ.
अब हुआ सर.
नहीं हुआ. कब पे फिर करना पड़ेगा. इसमें एक ऑडियो विजुअल म्यूट. यस सुरेंद्र.
चलो शुरू करो सुरेंद्र जी.
डॉक्टर सुरेंद्र अनम्यूट करके स्टार्ट करो.
यस सर.
एक ओपन करना, दोनों इको होगा.
बंद करो एक तो.
एक को बंद करना.
इसको बंद कर दे.
यस.
स्टार्ट हो गई सर.
हाँ, स्टार्ट कर दो. यू आर नॉट ऑडिबल अजय सुरेंद्र.
हो गया भाई.
अभी आ गया था ना फुल स्क्रीन यार.
स्टार्ट करें.
फुल स्क्रीन करना पड़ेगा ना, फिर दोबारा कब पे जाकर. हाँ, हो गया.
ये क्या हो गया फिर?
Good, good, good. Now we can start.
ये किस और में स्टार्ट किया?
अरे
हाँ,
और
yes.
चलो ठीक है।
सर आप स्टार्ट कीजिए, मैं नेक्स्ट कर रहा हूँ।
Next.
बिल्कुल.
The next slide. Thank you, sir. Sorry for inconvenience because of the internet connection here is a very poor. And whatever things are here for the error. Just I am presenting the case. Sir, अब दिख रहा है?
हाँ दिख रहा है अब।
Yes,
Yes, sir.
audible and visible both. You start with.
The Mr. Tarachand, I am presenting the case history, particularly the few patients presented in our diabetic center. Regarding the few abnormal things, the one of them I am presenting here, Mr. Tarachand is a 66-year-old resident of the Bikaner and presented in a diabetic center seeking to as a routine checkup and for the medication. As in course of evaluation, we recommended HbA1c test to know about the glycemic control or the glycemic status of the individual. Initially, HbA1c, we advised about the HbA1c here. HbA1c test, the result was 1.2 and a first reading. We consider it as it could be the false reading. Therefore, advised to repeat it, and the repeat test again reveal the HbA1c value is approximately 2.6. Therefore, the two reading in front of us about the HbA1c. This prompted us to delve into his past history as well as the thorough medical evaluation of the patient. Next slide.
Dr. Amit Thakur.
As per concern about the medical history, and briefly I will summarize about the history of the patient here. And in 1999 first time this patient was reported with a blurring of the vision in front of the ophthalmologist, and he diagnosed as a glaucoma, and that during routine pre-anesthetic checkup he was discovered as the high blood sugar and ophthalmologist referred to physician and he was diagnosed as a diabetes and the treatment started treatment.
Dr. Amit Thakur, your voice is making disturbance.
Dr. Amit Thakur, kindly mute yourself.
Dr. Amit Thakur, please mute yourself.
And the initially HbA1c, he was diagnosed with the diabetes mellitus and they received the treatment without initial HbA1c test. Initially, he took the simple medicine as we advise in the government setup, as well as the other things is made for me in the Glimepide as a once of the therapy, once a day therapy till the 2017. The few readings after the glucometers, after the consultation suggestive of the blood glucose level was fluctuating. Therefore, he switched on twice a day on the anti-hyperglycemic drugs. The next slide. And in 2000, he underwent as a left eye glaucoma surgery. After glaucoma surgery, he was comfortable, and he developed a few complications like the coronary heart disease. In 2017, again he was operated for the heart, and he did and the right eye operated in 2020. For the cataract surgery point of view, again on the left eye operated 2021. He also having complaining of the various complications of the chronic diabetes in between the period of 2019 to 2022 in form of the peripheral neuropathy, in form of the diabetic foot, as well as the frozen shoulder. Next slide, boss. In between the period and the patient had never undergone an HbA1c test until a recent routine checkup with a day of physician. Accidentally, and in 2021, he reported in the satellite hospital, where again the HbA1c was done, but the one sample again rejected. Upon this, again the second sample was processed, and it was again rejected. And as per the history which is given by the patient, the rejection which is told by the doctors could be the technical error. Subsequently, he refined from the voluntary participation in the sample collection. He maintained the blood sugar with a regular exercise as walking 3 to 4 kilometers per day, and managing the diabetes with the help of the drugs along with the exercise and lifestyle modification. Next slide. During this hospital visit, he was recommended to undergo HbA1c, because the HbA1c already has been done twice, and that both time HbA1c below the normal. The one is a 1.2 and the second time is a 2.6. Then I advise about the glucose tolerance test, challenging about the 75 glucose in a 200 ml of the water. And we recorded the fasting and the 2 hours reading of the blood glucose. The fasting reading around the random blood sugar 135 and as well as the 265. And a few investigation also be done simultaneously. The insulin level in a fasting stage around the 100 ml unit per liter, and the C-peptide around the 4.5 nanogram per ml. CBC routine examination was normal, and a liver function test, SGOT, SGPT, as well as the albumin within a normal limit. I couldn't find out any abnormality in the renal function as well as the liver. Next slide, please. USG only showing the grade 1 fatty changes in the liver, but the kidney right side as well as the left side within a normal, no CM, maintained CM corticomedullary differentiation. Next slide. As per concern about the family history, entire family having the diabetes, one younger sister and the 2 younger brother having the type 2 diabetes mellitus. One sister already has been died in 2022 by the cardiac arrest. Apart from this, no significant non-history of the parents about the diabetes. As per concern about the person, is a retired clerk. Socio-economical status is a lower middle class. Married individuals, vegetarian, is non-alcoholic, non-tobacco chewer, occasional smoker. He has history of the drug allergy, particularly few tetracycline, doxycycline, as well as he told us about the NSAID and the ciprofloxacin, ofloxacin, fixed drug eruption with the tinidazole as well as the metogil, as is told. Next slide. On general physical examination, the vitals are totally stable, the blood pressure 110/70, the pulse 84, and the oxygen saturation around the 94, respiration rate 70 per minute. No sign of any chronic illness are there about the failure of the kidney or other the failure of the liver and whatever things will there, chronic complication of the diabetes. Next slide. on systemic examination, except the central nervous system examination. Deep tendon reflexes also within a normal limit, but complaining of the tingling and numbness in the bilateral lower limb since last 3 years, starting on the lateral side of the bilateral fifth phalanges in the 4th to 5 month back. Could be it is a part of the peripheral neuropathy. Next slide. Respiratory system usually within a normal limit. Cardiovascular system, we couldn't find out any abnormality, S1, S2 normal, and then no murmur or additional finding in the cardiovascular system are here. Next slide. As per concern about our observation about this patient, HbA1c, as we know very well, is the most reliable test with a specificity of the 94%. It is one of the important choice of the investigation for the diabetes mellitus inducible patient for the monitoring of the blood glucose. We notice particularly in this patient the why such type of the thing happened in a high blood sugar. The why do not repeat test or the why the do repeated test showing the insignificant value. Why did it go unnoticed from last 20 years? What is the pathology and physiology behind the abnormality in the HbA1c? Is there any genetic predisposition are present about the HbA1c point of view? Or the patient having the some part of the hemoglobinopathy or other hidden complication are there, which is related to the incorrect information regarding the HbA1c. So this is a big questions. Now what to do? The basic things are here. What should be done in such type of the cases? And how many others ignored such type of the patient or the unnoticed cases has been inside the community? This is the big question. The next slide. Just I briefly enumerating here the false low HbA1c causes usually day-to-day practice we are reported here. One of them is a pregnancy. The induced value is a hemorrhagic tendency. And suppose somebody is consuming about the erythropoietin because of the CKD patients or the repeated blood transfusion or the hemolytic anemia and the cirrhosis of the liver, certain type of the hemoglobinopathies. These type of the inducible usually having the low HbA1c values has been seen in a various literatures. Next slide. On the other hand, the few example of the false elevated of high HbA1c, particularly in the iron deficiency anemia, particularly in the chronic kidney disease, particularly in the vitamin B12 deficiency, and in the certain group of the ethnic groups and the individual who consuming the alcohol as well as the chronic opioid users, having the higher site of the HbA1c apart from the age and the pregnancy. Next slide. Few variable changes in the HbA1c already has been seen in the various type of the hemoglobinopathies or the suppose the individual having the high concentration of the fetal Hb hemoglobin with hemoglobinemia, suppose some individual having, and the sum is a genetically determinants, genetically abnormality, particularly gene which are responsible for the beta chain in the hemoglobin formation. Next slide. Now a few things regarding about the introduction regarding the HbA1c. HbA1c, as we know very well about, the crucial marker in a diabetes management for the diagnosis of the diabetes, for the monitoring of the blood glucose in the diabetes, and for the prognosis as well as the monitoring of the complication, chronic complication of the diabetes mellitus. It gives information regarding the 2 months, at least 6 to 8 weeks in a diabetic individuals. I don't want to go in a detail regarding about the normal values. As less than 5.7, 5.7 to 6.4 is a pre-diabetic, and more than 6.5 is a diabetic. Next slide. So what is the reason behind the discordant? Or the pitfall about the HbA1c value? The few things I highlight here. The one of the reason is a biological factor that can produce abnormality in the HbA1c. The biological factor, particularly the rapid turnover of the red blood cells, is one of the factor. Whatever reason behind it, hemoglobinopathy is a second reason, then anemia and the chronic kidney disease is another etiology. Inter-laboratory difference is one of the criteria that will give the different values. So we should be confirmed. Repeated HbA1c test should not be rely on the single laboratory investigation. Inducible variability in form of the difference in the glucose metabolism in the different individuals, as well as the red blood cell turnover in the different individuals, as a variation in the glycation index, as well as the acute complications, sometimes giving the false result in a HbA1c value. And a 2066 and a diabetes care and a 29 volume and the page number 39 to 43 as a twin study already has been shown the HbA1c has a heritable component of the variability which may preclude a linear relationship between the blood glucose and HbA1c. Next slide. Suppose the such things are present in front of us. There are the several challenges in front of us. One thing is a misdiagnosis. One second thing is a misclassification, where we should be keep the patient, whether the normal or the pre-diabetic or the diabetic. What treatment therapy we will advise the patient, because the maximum guideline will be based on the HbA1c. How can we assess the prognosis of the individual? And the monitoring challenge is a very important aspect of what things we should be use, second part of the HbA1c. And the lastly is the confusion and the frustration, how we will manage the patient, such type of the patient. Suppose the individual who having the misparity in a HbA1c as well as the blood sugar level. The next slide. Now this is a simple algorithm by which we can easily go through the discordance in a HbA1c in a diabetic individuals. The clinical examination is one important part of the HbA1c assessment. Suppose the such type of the individual having the low value of the HbA1c, repeated HbA1c measurement is a very important part. Additional glycemic markers like the glucosamine, like the CGM, like the self-monitoring of the blood glucose and the other parameters which help us about the monitoring of the blood glucose. Assess the variant in between the, suppose the we has facility in our site or the our college, assess the hemoglobin variants, suppose the facility is available. Consider the alternative markers for the apart from the HbA1c like the glucosamine, glycated globulin as well as the other things. After this, we should be make the individual target for the goal of the individuals. Patient education and the communication is an important part. Everything should be explained, suppose such type of the reading are present in front of us. Next slide, please. As assessing the clinical context, review the medical history is an important part. Evaluation about the glycemic status of the individuals. Analysis the patient treatment, particularly the adherence is present or the not adherent. Association of the comorbidities must be searched out during the examination, and then look for the recent strategy about the management of the diabetes apart from the HbA1c or the other infective etiology or the acute illness are associated or the not. Next slide, please. These are the assessing about the additional glycemic markers, which suppose the individual having this such type of the abnormality, we can go through the self-monitoring of the blood glucose. We will advise the patient for this CGM, We can go through the fructosamine for the accurate measurement of the glycemic status of the individuals. Next slide, please. Assess the hemoglobin variant is a very important part. The confirm presence of the hemoglobin variant here. First, confirm with the help of the electrophoresis with the HPLC technique. Understand the effect of the HbA measurement in the difference variant can lead to alternation in the HbA1c level. Suppose that no such type of the facilities are not available as the periphery site over primary and the secondary center. Such patient usually refer to the higher center for the further stratification and the investigation. With the help of the reference, we can manage easily and such type of the individual, suppose the diagnosis already has been settled down. The next slide. The individual who having the abnormality in the HbA1c or the patient having the discordance form of the HbA1c. The other markers we can be used as a tool for the assessment of the blood glucose, like the glycated albumin, like the 1,5-anhydroglucitol, or the continuous glucose monitoring is one of the important procedure by which we can find out the glucose abnormality and the variability in the glucose, blood glucose value. The next slide. What should be the basic goal in such type of the individual? If the such type of the discordance are persist and cannot be addressed properly, it is a crucial to individualize treatment goal based on the patient overall clinical status, comorbidity, and the glucose variability. The supporting things are helpful. Suppose the HbA1c is very low. SMBG as well as the CGM is a very important part for the such type of the patient management. Next slide. The patient communication is an important aspect. We should be clearly and openly communicate with the patient. Explain everything about the limitation about the HbA1c point of view. Education patient about the factors that can affect the HbA1c result. And they emphasize the importance of the regular monitoring of the blood glucose to the patient and adherence to the prescribed therapy. This is the important part. On the next slide. The other other case also be reported oversight is the patient of the hemolytic anemia, thalassemia major, suddenly presented with the diabetes mellitus, with the iron overload and the diabetic ketoacidosis. HbA1c was very low. Shortened red blood cell lifespan situation is one of the criteria of the abnormality in HbA1c here. Surprisingly low HbA1c in these individuals, but the blood sugar as a routine by the glucometer is very high. The underlying pathology, as we think, the shortening of the lifespan of the red blood cells due to the anemia leads to disproportion or the representation of the mismanagement, disparity in the blood glucose level as well as the HbA1c. The next case, the sometime in the gestational diabetes mellitus is one of the category in which the HbA1c usually reported on the lower side as compared to the blood glucose level. The underlying pathology about these things are the pregnancy-induced changes in the red cell turnover, which is responsible for low value of the HbA1c and the difficulty in the interpretation of the HbA1c during the gestational diabetes. Next slide. And the third case is a chronic kidney disease individual. A patient with the diabetes and the underlying chronic kidney disease. HbA1c results are paradoxically low in spite of the very poor glycemic blood sugar control. The underlying issue again the same is the red blood cell lifespan associated with the kidney disease affected by the HbA1c accuracy. So therefore, the HbA1c is not the single criteria for assessment of the glycemic status of the individuals. Next slide. The ultimately in the nutshell, I concluded here the discordance in a HbA1c measurement is commonly in a diabetes with the various factors. Assessing the clinical context is a very important aspect to find out what is the reason behind the discordance of HbA1c. We should be consider the alternative marker like the glycated albumin as well as the CGM as well as the glucosamine for the individual who having the abnormality in the HbA1c. Individualizing treatment goal based on the patient character, improvement of the outcome, regular monitoring and the adjustment are essential for the optimized glycemic control. Next slide. There are the few limitations about the HbA1c as a surrogate marker. Using of HbA1c alone to guide about the improvement in the glycemic control has not been as an optimal value. Other methods we can be used simultaneously. Sometimes suppose the such type of the discordance are present. HbA1c do not identify hypoglycemia as well as the glucose variability, which are basically responsible of the various atherosclerotic processes as well as the chronic complication. HbA1c can be affected by the wide range of the physiological as well as the pathological conditions. Wide range of the glucose profile can be associated with given HbA1c value because the HbA1c giving the single value, but the individual having the variability in the blood glucose level. Next slide. These are the various factors that alter the concentration of the HbA1c in the blood. Already I has been discussed about these things. The few is a physiological stage, few is a medical therapies, few drugs are associated with the abnormality in the HbA1c result, and the few things, diseases particularly are associated with the HbA1c result. The clinical examination as well as the HbA1c value. Suppose the HbA1c value are the lower side or we are thinking it is abnormal as the clinical presentation of the patient. So we should be correlate clinically and they thoroughly examine the patient before interpretation of blood glucose or HbA1c result or writing about the prescription. Next slide. Thank you very much.
Thank you, Dr. Surender, for giving an important information regarding the HbA1c. Quite often, quite frequently, we are advised for HbA1c estimation, and many of the time we forget to see whether patient is anemic or not, thalassemic or not. Pregnancy is there. Even in the pregnancy, we quite frequently advise for the HbA1c, which cannot be relied upon. So your information has brushed up our knowledge regarding the reliability of the HbA1c. And if we talk about the HbA1c, for around 10 or 15 years, there was difficulty for the standardization and validity of the HbA1c. And different methods used to give different values. And HPLC is the best way and most authentic way to find out or to measure the HbA1c, which still even today is not available in many of the towns. So as such, HbA1c is a good marker for the seeing average blood sugar of last 3 months, but these pitfalls we have to keep in our mind. But quite frequently we see the patients of the anemia, thalassemia and pregnancy, we usually find the values after 4, 5, 3, but not like that of the 1.2 or 2.6 which you have mentioned. So could you find out the cause for low HbA1c in your patient?
Sir, actually, all investigation done at the oversight, the investigation. But I think as the brother and sister also having the diabetes mellitus, I call them for the HbA1c testing at oversight and the over center. But still, I'm unable to find out the particular reason behind the too low HbA1c.
Okay. So that was done by the different laboratories and different methods.
Yes, sir.
Still, it was very low. It was too low to be explained by the anemia or pregnancy or something else or thalassemias. But still, there must be some hemoglobinopathies or something else.
Yes, sir. Hemoglobin.
Ajay Shah?
Yeah.
Yes, yes.
I recall.
You wanted to speak.
So in my course of practice, so there was this staff nurse with diabetes who reported with a very similar value, 1.5 or 1.6. Now she's retired. So we did a hemoglobin electrophoresis on her, and she was thalassemic. So I guess that this patient comes from Bikaner, as was mentioned in the history, which is a pocket for thalassemia or sickle cell, either of which, and therefore I should be recommending hemoglobin electrophoresis, not only on him, but even on the SIBs who got diabetes. So other pregnancy is not possible in this patient. Hemorrhage is not possible. Liver, kidney were normal. So this probably should be done. It's easily doable test. And if you look at just the HbA1c graph, which is done by the HPLC method, the graph actually shows the hemoglobin variant. And that clinches the diagnosis itself, although you need to still perform the hemoglobin electrophoresis. So as far as monitoring is concerned, as has been pointed out very nicely, if the gold standard test is not there, one should be relying upon either SMBG or CGM as the monitoring parameters for this patient. Fructosamine is available through the ThyroCare laboratories. It tells us about the glycemic control over 2 weeks, which is about the same length of time which the CGM gives us. So if we are doing CGM, there's no point in doing fructosamine again. So CGM is now readily available, not all that costly. And I think SMBG and CGM should be done. Hemoglobinopathy we can do. That has a genetic implication as well.
Nowadays, thank you, Ajay, for giving your information. Yes, Dr. Daria, you wanted to speak something.
Yes, sir. Nowadays, when we are using that CGMS, that is also giving the HbA1c value of that 14 days. So, like in this case, if the HbA1c was low, like 1.6 and then 2.3, then we could have done that the CGMS, and that CGMS will give you the value of HbA1c also in for that 14 weeks. So if
Dr.
there would be
Daria,
any hemoglobinopathy, then that may be a rule out by this CGMS also. If you are not doing the electrophoresis, you can go simply the CGMS. If the HbA1c is okay in that, then that won't be correct in the hemoglobinopathies.
Dr. Daria, I would just like to state that the HbA1c that is depicted on the CGM report is the A1C. That is, E stands for estimated and not the actual. And there is a difference between the actual HbA1c, which would reflect past 3 months or 4 months glycation, compared to estimated HbA1c, which would have shown for maybe 10 or at the most 14 days. So there could be a discrepancy between A1C and actual HbA1c.
Dr. G D Ramchandani. will you like to put some light on this aspect? You quite frequently see type 1 patients, young patients, pregnant patients.
Thank you, sir. First of all, I would like to congratulate Dr. Surender for a wonderful case and wonderful presentation. Frankly, we was just remembering our medical days, how to present the case. Truly amazing. For that, I would like to appreciate his clear message about the A1C. Of course, this case was definitely very interesting. Sometimes, कभी भी report आती तो ऐसा नहीं है गलत यार, it cannot be possible. Once, twice, but if any report is there, 4, 5 we used to see in type 1 diabetes with thalassemia. Thalassemia is very common in type 1 diabetes, and we have a good series of type 1 diabetes with thalassemia because of the iron overload or this. And similarly, in pregnancy also we are doing less A1C, but practically below 2, I have not seen in my clinical practice. And of course, if there we should confirm with HPLC method, which is gold standard, and still it is low. Definitely treatment is already discussed with Dr. Surender and Dr. Ajay Shah that how to manage such patients. And this, I again appreciate this presentation by Dr. Surender and the case day-to-day practice which we are facing in our practice. That A1C is not only the only test by which we can manage, but if some errors or discordances there, definitely you should go for this ambulatory glucose AGM as well as some other methods to control the glycemia in future, in later time. And I request Dr. K K Pareek sir about his experience about this such type of patients in their day-to-day fallacies that are there in A1C and how we should proceed in such cases, sir.
So,
Dr. Pareek sir,
really, yes. Congratulations, Dr. Surender Kumar, for a very excellent presentation. And I think the Dr. Shah has already said that one must exclude when this is really a very different A1C I've never seen, and I never thought that HbA1c can be of this much value down. So we must exclude when we think such a different HbA1c. We must not blame only laboratories or some other things, but we must try to find out what is maybe we should exclude the possible causes, and one of them is so common, thalassemia. So electrophoresis is very important, and the other causes which Dr. Surender Kumar has enumerated must try to exclude. It's really an eye-opener for all of us that the HbA1c can be of this much value. So it's really a good case and good case for discussion also, and we had a good interaction and discussion also. Thank you, dear.
Thank you, sir. Thank you for your kind words. And we have to keep our eyes open. Whenever we find discordant HbA1c, we should think of other options also. Dr. Pradyuman Sharma, would you like to say something?
Abbas.
Yes,
Yes,
will you
yes.
like to say something?
Let me appreciate the way he has extensively discussed. But I still shocked to learn and understand the A1C to the extreme low levels. And once it is at such a low level, we should never give away any weightage. Number one, this fellow had so many problems with cataract, cardiac disorders, and angioplasty, but he had never been investigated for A1C. That's again a surprising. Number two. Number three, in CNS examination, this fellow had a cervical spondylitis, or could be as a, because he had a presentation in the arm, but his foot examination has not been extensively done. His foot sensations, look for the diabetic peripheral neuropathy, diabetic foot should have been also evaluated, because in such a case, you are leaving alone and not examining a foot, something is surprising. But anyway, my all congratulations, and we understand, but such a low A1C we have to see again and again. Thank you and congratulations.
Thank you, sir. Thank you. Dr. Khinsra, sir.
Very nice presentation. We enjoyed the talk. It was really very interesting case. Many times we also sometimes think that laboratory is not correct. but we should think in that way also. Any low A1C should think for other causes of low A1C. It is a very nice talk, interesting case.
Thank you.
But in
Thank you.
Ajmer, sir, Prakash bhai, in Ajmer, sir, there are so many thalassemia patients. So about 4 to 4.5 SB1C तो मैंने कहीं देखे हैं.
Yes.
With Crohn's disease also, he is also suffering from gluten intolerance in type 1 patients.
Yes, yes. Up to 4 we also see quite frequently, because there is a big number of the patients of thalassemia in our hospital which come to us repeatedly, periodically for treatment to our department. But of this much low, I have at least not come across with the 1.2 or 2.6.
But sir, presentation of Surender Kumar was excellent, wonderful presentation.
Yes,
Congratulations,
yes.
Surender.
Yes, so
Yes,
Thank you, sir.
congratulations, Dr. Surendra. Everyone
Thank
is
you, sir. Thank you very much. Thank you.
Anyone else which you will like to put some light on this?
Dr. Rakesh Pareek is also here. Any comment?
Yes,
from
sir.
you?
Sorry, I was a little late, so I missed the initial part. But then it's again very interesting to see such case. My only suggestion is that probably there are very few cases of such low A1C that are reported. So this case probably deserves a reporting as a
Yeah.
case report.
Yes,
So-
already he has been sent the report, sir.
Good.
Have you already submitted for case report?
Yeah.
Journal? Okay. And for that, but then probably will require hemoglobin electrophoresis. Have you done that, sir?
Yes.
Okay. So
In
in
our
that,
setup, ion exchange chromatography is available here. Already we has been done this with the help of this twice or thrice such type of the reading for it. But one of the important reliable method of the estimation of the HbA1c.
no, I'm talking about HB electrophoresis. So have you done that?
Not done that. Not.
So
not.
I think it is better. Like already, if you
Yeah, I
have
will
submitted,
try,
that's
I will-
fine.
Yeah.
But it's better. Probably we can take the help of SMS hospital, and this case deserves a better workup, because it is very likely that she or he might have some kind of hemoglobinopathy rather than thalassemia or sickle cell. Because this low HbA1c, even while I was listening to you, I was searching on net. The lowest A1C reported, I could not find a report showing such a low A1C. So my request is that probably we should submit this in a good journal and publish that.
Yeah. Okay. Thank you.
Thank you. So,
Dr. Daria, any comment from your side?
I think, sir, we must find out the cause for that such low HbA1c. If the facilities are not available there, then you can send the blood sample or the patient to the higher center, so we can get the exact answer for that.
I
Yes,
will try to
look at
send the sample and I will try to find out the reason behind it. I'm searching.
Yes. Thank you, Dr. Surendra. And I will like to thank all, Dr. K K Pareek sir, our mentor, our guide, and all the senior persons who have joined us to boost our morale, Madam Alka Deshpande and all the other seniors. Thank you very much for joining us. And again, next month on second Thursday, we will meet here for this case-based discussion on diabetes. Thank you, everyone.
Thank you, sir.
Today,
Thank you.
good
very
thing
Thank
is
you,
that
sir.
so many
Bye-bye.
people, sir, today so many people are joined from out of Rajasthan also.
Yes.